All right, welcome everyone to this Goodfellow webinar on behavioural change strategies for the reduction of addictive behaviours, a focus on alcohol and gambling. My name is Grace. I'm a GP in Auckland and I also work for the Goodfellow Unit. Tonight I have with me Dr. Simone Rodda. She is a senior lecturer at the University of Auckland and an honorary research fellow at Deakin University in Australia. Over to you, Simone.
Hi everyone, good evening. Hope you had a lovely dinner and it's not too hot in your house this evening. So I'm really pleased to be here today to talk about a project that we have running, or a series of projects that are looking at behaviour change strategies for reducing addictive behaviours. So just to disclosures starting off, I've received funding from various sources, but no funding from the gambling industry, which is particularly important in gambling research as well as alcohol. So today we're starting off with a bit of a context, and I'm going to provide you with an update on the changes to the DSM-5 for alcohol and gambling. Then looking at a brief overview of screening and brief interventions for those conditions. And then we'll be focusing on an update to self-management techniques for alcohol and gambling, as well as sugar and internet reduction. So these are really practical behavioural strategies for change, which hopefully will be useful to you as well with working with people. And we'll be looking at a way to be able to implement those with a goal-directed approach, and then some tips for being able to do that. Okay, so an update. So up until it was 5 years ago, it's actually 5 years ago since the DSM-5 arrived, which is the Diagnostic and Statistical Manual for Psychiatric Disorders. And it used to be that alcohol was a categorical condition. So you had alcohol abuse or alcohol dependence. In the DSM-5 that changed, and it's a continuum now. So it's a continuum of alcohol use through to mild alcohol use disorder, moderate alcohol use disorder, and severe alcohol use disorder. That has ramifications for how we think about substance use disorders, and that's the case for all substance use disorders, where they have moved to this continuum approach. So it doesn't mean that the items disappeared, and in fact the items are more or less the same as what they were in the DSM-4. And you can see here the red were the alcohol abuse items previously, and the black were alcohol dependence. And so what the researchers have done is merge those items all together to come up with this continuum approach. So it's still got items around having more alcohol than was intended, difficulty cutting down, more time is spent getting alcohol or recovering from its effects, craving and harms, as well as tolerance and withdrawal. So those sorts of things are all still there. Now, gambling has also had a huge amount of change in the last edition. So gambling used to sit with the impulse control disorders, with kleptomania, pyromania, trichomania, and problem gambling sat there. So the new impulse control disorders look quite different, and you can see them on the screen. So it was decided, primarily due to funding reasons in the States, that gambling looked more like an addiction. And so now it sits with the substance use disorders as an addiction, and it is also considered to be on a continuum. So it goes from gambling use to mild gambling disorder, moderate and severe. And so you'll notice that the cutoff for mild gambling disorder is higher than for alcohol use disorder. And I think that's just working out what the appropriate criteria should be. So in terms of the items, originally the gambling disorder criteria came from the substance use disorder back in, it's been around since the DSM-3. So it includes items related to tolerance, withdrawal, difficulty stopping, preoccupation or spending time involved in it, and harms as well. And so you can see number 8 is around the harms. It also includes gambling specific items, and the ones in yellow are the ones that are quite specific to gambling and aren't in the other substance use disorders. And so that's gambling as when feeling depressed, chasing money. So this is where someone tries to win back their losses by gambling again the same day or the next day. That they lie to conceal the extent of involvement with gambling. Now, one of the reasons why this happens is compared to alcohol or drug disorders, you can't actually see the effects of someone being intoxicated by gambling, for example. So they could be sitting in front of you, they may have just been gambling and you probably wouldn't know. And so it's much easier with gambling to conceal what's happening because you haven't got that physical expression of it. And lastly, the inclusion of bailouts is where people attempt to get money from other people in order to relieve their financial situation. So you can see that some of those are quite similar and some of them are quite specific. So some research in the field and this is really the in the last couple of years, really important research where we've been looking at the impact on quality of life from gambling disorder and alcohol use disorders compared to other substance use. And gambling disorder is considered less severe than severe alcohol use disorder or heroin or opioid dependence, but more severe than moderate alcohol use disorder or migraine or headache. And similarly, mild alcohol use disorder and low-risk gambling status yield similar decreases in quality of life and similar to hearing loss or moderate anxiety disorders. And so this really complicated looking graph here really just ranks the impact on quality of life from these different conditions. You can see at the top schizophrenia, multiple sclerosis, and then heroin and other opioid dependence. In terms of the prevalence of these disorders, and this is perhaps a way useful information in terms of how frequently you might see someone with alcohol or gambling disorders. So the latest research suggests the prevalence of 12-month alcohol use disorder is around 30%. And so that's including mild, moderate and severe categories. So with the DSM-5 changes, there are more people that now have been diagnosed with problems because of this mild category. In problem or gambling disorder, the same thing has happened. So in New Zealand and pretty much around many countries, the prevalence rate is around 1%. So that's quite similar to Australia, depending on how it's measured. But when we include the people that are at moderate risk or low risk for gambling disorder, so they are reporting some symptoms of problems associated with their gambling, we're talking around 8%. And we know through our other research that people attending mental health or allied health have a greater chance of gambling as well as having problems associated with their gambling. Unfortunately, they're not routinely screened, which is a different talk. So in terms of why we care about these low risk and moderate risk gamblers, the research that was done by Matt Brown from Central Queensland University just a couple of years ago and has been replicated in New Zealand has indicated that 85% of the total harm from gambling is coming from low risk and moderate risk people. And so these are people that are spending more than they could afford or are spending money from the household budget, and they might be binge gambling once a month and perhaps they're drinking alcohol at the same time. So that kind of just sort of gives you a summary of where we're at in terms of classification and also looking at the continuum of harm. So moving on now to some brief screening and brief interventions. So I started with the gambling this time, then moving to alcohol. One of the things that we learned from talking to clinicians is people didn't really know what tool to use if they were going to screen for problem gambling. And Nikki Dowling and colleagues at Deakin last year did a review which identified tools that could identify problem gambling specifically for in healthcare settings. And so you can see here there's 3 recommendations. And so these are really quite simple. So the lie bet, if you do have someone that you suspect might have gambling issues, a validated and reliable tool to use would be this two-item tool. So it's as simple as, have you ever had to lie to people important to you about how much you gambled? So that's picking up on that lying item. And have you ever felt the need to bet more and more money? And so that will detect someone if they have severe gambling disorder. The second screen there will detect anyone that's got low, moderate or severe gambling. So there's some sensitivity around these tools. So the longer one will detect people that are at low risk as well. So in terms of alcohol, you've probably seen this screen or a version of it before. This is the audit, which is a 10-item questionnaire that covers 3 aspects of alcohol use. alcohol consumption, dependence, and adverse consequences. So this is picking up the abuse dependence criteria as well as harms. And so it is scored across that 4-point scale that you see there. Now, what you might more regularly see in your practice, or that has perhaps come across your desk, is the 3-item audit, referred to the audit C. And the C stands for consumption, so this is audit consumption. It measures the frequency of drinking, the amount of consumption and intensity, and a score of 5 or more indicates increasing or higher risk of drinking. So these are questions around: how often do you have a drink containing alcohol? How many units of alcohol do you drink in a typical day? And how often have you had 6 or more units if you're female, or 8 or more for male? And so the recommendation is, if the person scores more than 5 on this, then they should complete the full audit, 10-item audit to fully screen. So what do we do with this? And sometimes you might be screening and you're just like, oh, I don't really, not sure what to do with this, or should I be referring to a treatment agency, or doing a brief intervention. So a few years ago, published in Lancet, is a recommendation of what to do with those screening items. So this is just a part of the diagram in the article, but it says if the person scores less than 8, they should not have an intervention. It's okay. 8 to 15, they'll have a brief intervention. So this could be a motivational interviewing intervention, and I'll touch on that a little bit later, for perhaps some people don't know about that, and periodic reassessment. If the person is scoring 16 to 19, they should receive a brief intervention with regular monitoring and perhaps further assessment. Those that are scoring at the high end, indicating severe alcohol use disorder, or up the higher end, it's recommended that that would be a referral to a treatment agency, and there are free agencies across New Zealand, and they would undertake a full diagnostic assessment, including history, presenting problems, alcohol and other drug use, mental health, physical and medical history, legal and cultural history, whānau and family support, personal development and spiritual, as well as cognitive screening. And so it's a fairly intense process after that. So we're really talking about today the people in the middle. So we're talking about the 8 to 15 scores and the 16 to 19 scores. So the ones that are the folks that are having some problems, and where a brief intervention may be appropriate. Okay, how are we tracking for time? Oh, we've gotten through that quite swiftly, which is terrific, I hope. Okay, so one of the reasons why we're really talking about this, and in addition to the recommendations of what we do with those types of screening tools, is that we know that even though there are free services, very few people, comparatively to those that have problems, use those services. So internationally, it's around 20%, or 1 in 5 people that could use the service because they have been classified as having alcohol or gambling problems, but they don't. And continuously the research indicates that people have a preference for self-management, which kind of makes sense. So, I often talk to people, look, if you find that you've got a problem, what's the first thing that you do? Well, firstly, you've got to work out if you have a problem. And probably the first thing you're going to do is jump online and see what you can find. And so this is exactly what we've found people with addictions are doing as well. Historically, it was thought that people naturally recovered or spontaneously recovered, which I always found was a very strange concept, because I'm not sure people naturally or spontaneously recover anyway. So interestingly, what we found when we've been doing our research is that actually they don't do that at all. They actually engage in a whole range of behavioural strategies to be able to make that change happen. And so these strategies are actions or resources that people use to limit their alcohol consumption or gambling behaviours. And we've done this research across sugar, internet pornography, internet gaming, smartphones, alcohol and gambling. And we've found fairly similar things across all these areas, that people engage in these behaviour change strategies to limit or modify their behaviour. And these may be used with or without professional assistance. So we have one slide on our methods that took a couple of years to develop. So let me kind of just orientate you to this, and this will sort of help through the rest of the talk. One of the things we know is that research looking at how people naturally change their behaviour has tended to focus on in-depth interviews, focus groups, secondary data analysis. So these are people that have sought help and are undertaking interviews with a researcher. And what this has meant is we had relatively small understanding of how people self-manage, because they typically were people that have gone to a treatment program or a 12-step group. And a 12-step group such as Alcoholics Anonymous or Gamblers Anonymous are a program of recovery. So what we heard before was pretty much the same sorts of things people were doing, and it was a very small selection of information. So what we noticed is that online there are literally thousands and thousands and a million stories online about how people recover from addiction, as well as a whole range of other conditions. So we developed this methodology where we were able to mine these sites and then process that information and repackage it back to consumers as a sort of consolidated set of guidelines around these conditions. And by way of just showing you what that looks like. So this is from our alcohol book and our alcohol guidelines. And this is a group of techniques we refer to as avoiding hotspots or avoid hotspots. And so this was about avoiding places where the person may be tempted to drink, such as restaurants, bars, clubs. Also to avoid events where they serve alcohol, and it might be difficult to have that self-control, especially in those early days of behaviour change. And so here what you see is this is the ideas that the main ideas that consumers had. We've rewritten, repackaged, but tried to use their own words, and then talked a little bit about what the evidence says and how they might maintain it. Similarly, this is another one called Cravings and Urges, and it has a great deal of detail around how to manage cravings and urges. So this is not from a researcher perspective or a professional's perspective. This is from a consumer perspective of what works for them. So this is quite a different approach to say, okay, maybe the consumer does know best in terms of what works for them in terms of self-management. So this is perhaps an interesting juncture where we think, okay, well, these are not evidence-based, but they're what people say works. So what do we do with that? And
just a question. How does outpatient services compare to inpatient services in effectiveness?
That's an interesting question. So what I would say broadly is if someone seeks treatment, the treatment will, for the most part, work for them if they engage with it and stick with it for a period of time. Okay. Would probably be one of the ways to perhaps think about that as a broad. Yeah. Okay. What's your next question then? Stigma. Yes.
I think it's more a comment with regards to stigma in the workplace.
Yes. Yes. Well, one of the things that we've found with this is by talking about what consumers do, it does remove some of the stigma around this as well, because it's what people say have worked.
Okay.
Yeah. So just to give you an example, and perhaps you have patients or clients that have some of these conditions, and you might be able to relate to some of these strategies. So this is the taxonomy for alcohol. And the way these taxonomies are structured is we use a model called the Rubicon model. So we don't use the stage of change model, which perhaps you've heard about. It's not an especially good model at predicting. And so we're using what's referred to as a goal-directive model. So the idea of this is the person decides that they want to change their alcohol use, and then they put in place some strategies to be able to do that for a period of time. So the way that you can see this slide is the pre-decisional is where someone's deciding amongst their many priorities about whether they'll deal with that addictive behaviour. Pre-actionals when they're putting together those plans. The actional is the actual work of making that plan happen and and then we have some multi-phase strategies, and then also evaluation at the end. So I've circled here consumption control, and what we found on the websites is people spent quite a lot of time talking about how to control their alcohol so that they could use have alcohol without it being a problem. And this is perhaps a surprise because it runs contrary to the traditional notion of an abstinence-based approach, but people talk about how can you do this. So they talk about things like changing the way they drink, so drinking slower, drinking from smaller glasses, using ice to dilute the liquid in that, or to weaken the alcohol content. So it's quite a bunch of things people do. The other thing we found in this is that people also talk about maintaining that readiness, and this is a huge gap we've found in terms of how health professionals can support someone's readiness between appointments. So what we're talking about here is generally interventions are about increasing readiness to change, to engage in an intervention, but not so much focus on how do you keep the person motivated or help them to keep themselves motivated every day they wake up and are faced with challenges. And you know yourself, if you ever tried to change something or engage in an exercise program or change the way you get to work or change how you have your lunch, it's really hard at first because you've got to keep yourself motivated. And so we found that consumers do a whole bunch of things, like they say, be positive, be determined, take it slow, exercise willpower, keep trying, don't give up, look at building confidence. So in terms of gambling, we found similar sets of strategies, but what differed with the gambling was more of a focus on avoidance type activities. So why this is of interest is that with alcohol, it's more difficult to avoid alcohol because of it being so much a part of our culture in terms of celebrations and weekend activities and meals. With alcohol, it's much more easier to avoid it altogether. So there were a lot of avoidance strategies. We also found across all of them these strategies around well-being, and these were about improving physical, mental, spiritual, and health, as well as sleep and eating. And so when we first identified this a few years ago, there was quite an argument with the researchers, like this is not a strategy for changing behaviour. But consistently we found this, and people talk about that it's important for them to be the best, the strongest version of them they can be, and then they're able to deal with the other things. So in terms of internet, and this was our taxonomy for pornography, gaming, and internet generally, we found that people really struggled to work out if they had a problem. And the reason for this is there aren't really very good screens for these concerns. And when someone says, I think I'm on my phone too much, or I'm playing games too much, they're not really given very good feedback about what too much is. And so it's mainly because there hasn't been research to feed back to people what too much is yet, and there are no guidelines around this. And so this is especially problematic for gaming that is having, starting to have such an impact on young people now and people in their 20s, where they're losing years of their life, where perhaps they could be developing relationships and employment, and not to have feedback seems a bit of an issue. Interestingly, for pornography, we found a greater focus on spirituality, and it's almost like alcohol was once 50 years ago a moral issue, and when talking about pornography, it's viewed as a moral issue that the person needs to, pray, or they need to seek guidance, spiritual guidance for their problem, rather than having a behavioural response as you might with any other type of addictive behaviour. And lastly, a project that we're just finishing at the moment in terms of doing this work is around sugar. And we found that a great deal of the time with sugar was spent talking about how to plan what you're going to eat. And the reason why people were doing this was that they struggled to be able to identify products that had sugar or were safe products. And then if they were eating out, what they could have that wasn't going to have sugar in it. When we looked at, being able to compare themselves against the guidelines for sugar, the websites we reviewed all provided different guidelines. Very few provided the WHO guidelines on the ideal amount of sugar per day or less than. And so people seem to be quite a bit confused about that.
Before we move on, just a couple of questions have come through. These taxonomy sheets are really interesting, and some people are just wondering if these sheets are available to be utilised.
Yes. So one of the I'll talk to you a little bit about some projects we have running in a minute.
Okay.
And so 2 of these are published already, and so I can.
Okay.
Yeah.
Fabulous. Yeah. And just one final one. Someone's just wondering, were there any suggestions that we should consider with regards to ethnic groups such as Aborigines, Maoris, Pacifica communities and migrants in this sort of taxonomy questionnaire?
Yeah. So all of our sheets have been reviewed by Maori and Pacifica. What we've found is that these seem to apply across culture. Ideally, though, what we've found here is that the categories tend to be similar, but the nuance or the detail is different. And so these still are at quite a broad level, and it uses an international sample as well. And so we've got it nuanced down to how the devil in the detail is different, but we don't quite have it down to cultural differences at this stage. So my guess is, and we've got a few projects at the moment where we're looking at how we can make these more relevant, is to get more detail around how people actually do the strategies. And I'll talk about that in a second.
Great.
Yeah. So what would you do with this kind of information? So this is one of the things that concerns us and researchers, and I'm often having to go, it's okay, is that these are not evidence-based guidelines. These are guidelines that consumers say work. So how can we package that up into some sort of evidence-based approach? Well, one way to think about this is, and a theoretical way, is with the theory of planned behaviour. So this theory is the most used theory in health. It's had about 50,000 citations of it. You know, it's a very robust theory. And the idea of it is, if you can identify someone's intentions to do something, it is a very good predictor of what they'll actually do. The stronger the intention, the better predictor of behaviour that is, most of the time. But as you would know, good intentions do not always equal behaviour. And over the last 5 or so years, researchers have looked at this gap between intentions and behaviour. And so the idea is to put an intervention in between someone saying, I've really got to change my alcohol use, and then putting an intervention in that doesn't try to increase their readiness to do it, but it increases their confidence and ability to do it. And so these interventions are referred to as action and coping planning. So you've probably heard action planning. It's pretty much sort of used as a general term now, but they actually mean something quite specific in terms of where the evidence base is. So what we talk to with our clients about is we help them develop these plans. And so we will say, turn the change strategy, so one of those strategies you've just heard, into a simple action plan. So start with, I intend to get into an exercise program, and I'm going to start doing that every day, 5 days a week, and I'm going to involve my partner in it. And so that's a very detailed action plan, for example. We then know that things get in the way of action plans, because often it will stop with the action plan and not deal with the things that get in the way. And so we will then ask participants what might stop you from using or sticking to the plan for the next month, which is the intervention time. And they list a bunch of obstacles. We then use a backup plan for the obstacles. So the obstacles might be, it's raining. It's a very popular obstacle to an exercise plan, rain. And so we would ask the person to develop a way of dealing with that obstacle, and we would refer them back to the booklets as well, or the guidelines as well, on how they might do that. So the key part here is to develop the if-then planning. And so if-then means that if this situation happens, then I'm going to do this. So if it is raining, then I'm going to take an umbrella. If it is raining, then I'm going to call my friend and we'll go to the gym. So it's identifying a situation that gets in the way and coming up with a plan. So there's quite a lot of research in health around this being very effective. One of the earlier studies was around flossing, and so you can see that simple plans turn into good outcomes. So I've yes, have you got anything on?
Someone just wants a comment on Al-Anon.
Oh yes, what is the question?
Literally, please comment on Al-Anon and the same with drugs for codependence.
Oh yes. Yes, so that's a terrific comment. And Al-Anon, for those that aren't familiar, is a 12-step group or a 12-step program for people that are family and friends of people with alcohol use disorder or gambling or opioids or whatever the case may be. And it is a program of recovery, the same as the other. So I would say that our program is quite different than Al-Anon in that it is providing practical strategies. However, one of the things that is lacking at the moment is a focus on how family can support people with these behaviour change strategies. So, and in fact, this first one is actually about how family can do this in some way. So this case study is around Emma. She drinks 2 bottles of wine a day over the weekend. So that's Friday, Saturday, and mostly on a Sunday. She's experiencing negative impacts from missing work on Monday quite regularly, repeated attempts to change and difficulty stopping. She wants to reduce her drinking to once a week and only 2 glasses on each occasion. So that's what we'd refer to as the goal intention. So her goal intention is that's her goal. She wants to reduce it to 2 glasses and once a week. So she identified the main reason for wanting to change was to improve her fitness, and she'd already started doing some things around fitness, and alcohol was really getting in the way with that over the weekend. She also identified a desire to stop drinking for her kids, and the main problem is her partner, who also drinks heavily. And often we find with people with addictions, there's someone else in the family that is either quite the polar opposite or is also engaging in the behaviour. So if we think back to the strategies we talked about before and what she says her issues are about, we can say, well, it sounds like she needs to avoid certain people, her partner over the weekend somehow, and to focus on some sort of alternative. So it sounds like, this is happening Friday, Saturday, Sunday. What else can she do? And so her planning is around getting out on the weekends with the children and preferably doing some sort of exercise to support her goals of increasing her fitness. When we talk about the obstacles, it's that the partner wants to come to, or that it's raining on the weekend. And so the plan would be if her partner wants to come on the weekend, then she will tell him that he can, but there will be no booze involved. And so that's kind of one way of involving whānau is telling or letting whānau know how they can support and help this. A different way would be to provide guidelines for whānau, and we've only literally just started doing this. But what we find is that the focus for family tends to be either focused on the person with the problem or focused on themselves and how they can help themselves through a very stressful and difficult period of time. And so in our initial work, we're looking at probably having 2 sort of focus of those guidelines. Yeah. So, and that's just revisiting where that is. So talking about alternatives and avoidance. So now I just wanted to reiterate. So when she said that she wanted to reduce her alcohol to 2 glasses a week, that's the goal intention or the behavioural intention. So often when we're talking about planning, the planning is focused on the actual goal rather than the how to get there. So it will be, okay, I want to reduce my drinking to 2 glasses, and the plan will be kind of, how are you going to do this? We're talking about making plans around specific actions, not around the goals per se. So let's look at Lenny. Lenny plays pokies 3 times a week. He bets around $80 a week, and he's on a pension. So it's not a great deal of money, but on a pension, that is a great deal of money for Lenny. His wife passed away last year, and he goes to the club to socialise. He's experiencing negative consequences. He has some depression that he thinks might be associated with repeated losses, and he's skimping on his meds because of the money he spent on gambling. So that's a pretty regular sort of occurrence, that people won't spend money on medication. It's not that they won't, but they'll spend it on gambling first, and then they won't have the money to purchase what they need. So Lenny is stuck. He just doesn't know what to do. He wants to keep gambling as it's his only social outlet, but the consequences are really hurting him now. So if you think about the strategies that we talked about before, and you think, oh, okay, we've got this range of different things. He wants to keep gambling, but he doesn't really want to keep having the harms, and he needs some sort of social outlet. And so this is indeed what we've come up with, is that he wants to do something around controlling his spending while still going, and some sort of other social support offerings. So the plan is focused on reducing the money spent in the venue to $20 a week, and focusing on free activities, perhaps in the venue. Also looking into volunteering work as a way of socialising or filling the time. So the obstacles to this could be money running out too fast. So this is really common with people with poker machine issues, is that they might say, okay, I'm only going to spend $20. They get to the venue, they are gambling for 15 minutes, and they find that even though they might be playing a low denomination machine, meaning a machine that's 1 cent a line, which is around 20 cents a spin every 6 seconds, which means the money will be gone in about 10 or 15 minutes. And so people generally hope they'll win so they can play longer. So losing quickly is often a reason why people will continue. Depression, and so in this case, the plan would be to seek some advice from his GP around how to manage that, and motivation. And so it would be very difficult or challenging for him perhaps to follow up that type of referral, and so check-ins required. So his plan would be, if I go to the venue, then I will only take my allocated money. And so this is a strategy that's the most used strategy for limiting money spent in a gambling venue. And in terms of the volunteering, if volunteering doesn't work out, then I will try Gamblers Anonymous for social support. So that's the 12-step program as a way of getting social support, where it's a no-cost option, and also supportive in terms of extending his friendship groups. And that's those ones. So lastly, we have Jane, and I thought I would talk about the set of guidelines that we're working on right now, which is around sugar. Jane eats around 75, or eats and drinks around 75 grams or 18 teaspoons of sugar each day. That's 3 times the WHO standard. Most of the sugar is coming from energy drinks, so one large energy drink is almost all of that, and milk chocolate. And she complains of weight gain, difficulty sleeping, and tooth decay. She has tried cold turkey repeatedly to quit sugar, but has largely been unsuccessful. This is because she gives up in the first couple of days. So we conceptualize sugar as a potentially addictive product or substance, and we've come up with the same sort of taxonomy that we would have for the other addictive disorders. So if we think about it this way, and what her experience has been, then we're really looking at strategies like substituting, substance substitution, and urge management. So the reason why I say that is her main sugar is coming from the energy drinks. So the planning for her was to focus on swapping the energy drinks to no sugar options, and then longer term swapping to water. So what we notice in our research is that artificial sweeteners and substitutes for sugar look like they should look more like methadone to coming off heroin. They should be something that the person is transitioning through and off. So one of the reasons for that is that it may be that artificial sweeteners keep that a desire for sweetness going, and so the person then has cravings longer than what would be ideal. We also would look at an urge management plan, given that she basically stops after a few days. So one of the things we've found in our sugar data is within urge management is people talk about withdrawal symptoms similar to what we see across our other addictions. So they talk about headaches, difficulty concentrating, sleep disturbance, maybe sweats, and fatigue and irritability. And so we see this across the other addictions. And so what we would advise is that she comes up with a plan to manage those things. So the obstacles could be that there were no low sugar energy drinks in the store, or that she gives into the urges, especially when chocolate is brought home. It's amazing how frequently chocolate is found in a person's life, that they're given chocolate, they're found chocolate, it appears. So the backup plan would be, if I can't get no sugar energy drinks, then I'll buy a diet soda. And if someone brings chocolate in the home, I throw it out immediately or perhaps re-gift it. And so you can see how that's a very concrete plan. Now, the idea with all these backup plans is that the person has mentally rehearsed what they're going to do for when that situation arrives. So the situation of getting free chocolate is not that surprising. And the idea of the plan is that they can plan what to do so they don't have to think about it, and they can enact that plan as soon as that situation arrives. So it's similar to, a fire drill plan, perhaps, that you know if there's a fire drill what you're supposed to do. Not a fire drill, a fire alarm, an alarm. Yes.
Fair enough.
Oh, is there a comment on, is that so stevia? Yes. Does that say stevia? Please comment on stevia.
Sativia.
So, what's stevia? Yes. Is that stevia? As the artificial
sweetener.
Yeah. And so some people in our research said that stevia was a solution where they didn't have those cravings or the bitter aftertaste. So people talk about a bitter aftertaste they don't really like either. But others have found that it still maintains that craving for sweetness.
Okay.
Yeah. It's interesting. And so that's where they come from. So have we got any other questions at this stage about this before we talk about?
I think we're going to move on to some of the questions about motivational interviewing.
So this last one about the underlying emotional pain that people use the addiction to control. Thank you so much for that question. According to these guidelines, we thought that underlying reasons, and you can see it kind of up the top here. So the underlying reasons were barriers to the person engaging in behaviour change in the first place. And so these are things like they might have co-occurring depression, trauma, a history of domestic violence, through to anxiety, or with our gaming group or pornography, there was discussion around social anxiety and a preference to do things online. So we kind of had thought it was there, but since our last run through the data and we collected a bigger sample, we actually found that perhaps those underlying reasons get in the way when people are also engaging in that behaviour change, and they do look a little bit different across the addiction areas. But the common things are around managing negative emotions. It's also about managing a history of some sort of problems, and so we do apply some basic strategies about how to decide whether or not you should seek professional help or counselling or psychotherapy or psychology to be able to manage this or self-manage. So yeah, it's a good question. So the idea of these are the very concrete behavioural strategies that the person should be able to implement even with those underlying issues. So, for example, sometimes when people get out of that cycle of addiction, some of those issues kind of go away because depression and anxiety comes from being in a cycle of addiction. Yep. Okay, so here's some tips for assisting patients to maintain engagement in behaviour change. I think that an ideal way of supporting these guidelines, and this is the approach that we use when we're talking with people, is we use motivational interviewing. So I'm not quite sure how familiar people are with motivational interviewing, but in essence, it's about supporting a person to do what they want to do and to elicit their own strengths and competencies in order to do this. And so it's very much about working in collaboration and supporting that person in developing their own autonomy. And so I think this one probably kind of gives a good snapshot. So typically, if you're working in a health setting, you're probably doing more of the right-hand side of the screen. You're probably in a position of authority where you are providing the person education, information, advice, and guidance in this case. So with addictions, there is a great deal of research that supports the idea of evoking that information, resources, and motivation from the client. So very rarely would someone with an addiction not already have done some research or tried some behaviour change before they talk to someone about it. And so by the time that person gets to you, they already would have tried a bunch of different things. And so, as with the case studies before, identifying what it is they want to do, what it is they think they need to do it, but then giving them a bit more information or instruction on how to do that perhaps is more helpful. So the way to do that is with a technique called OARS, and OARS is using open questions about what they've tried before, making affirmations such as "you're brave to disclose this," using reflective listening, "I hear you were worried about it," and summarising. So the great challenge of this is that it appears that it will take a long time because you're not jumping straight into sorting out the problem and giving a solution. But for just a little bit more time, you will find that your client will go away feeling like they have more competence and autonomy, and they've made their own decisions, and so they're going to be more likely to carry those decisions out. And so that's where these strategies we came up with have been really helpful. And so I've got one of the books here the alcohol book we're working with. And so we're able to give them the book and say, look, here's what other people did. What catches your eye with these? And what do you think you could do from this? So we're kind of giving a prompt for them to come up with their own ideas, but giving them really good guidance on how to come up with their own ideas. And so it's an interesting way to use these two. So the last part of this would be to assist people with implementing these behaviour change strategies. And my guess is you already have some of your favourite behaviour change strategies that you advise people on. So it might be you advise them just to stay away from places if it's gambling. You might advise them to chuck away all their alcohol and just avoid alcohol if it's alcohol. If you're working with someone with sugar problems, you might advise them to try a different diet, perhaps. What is missing in some of this is how to actually implement them, and this is what this research is trying to do. So it's a bit like at the moment is, and this is one of the campaign information, and the campaign information from Health Promotion Agency and other agencies tend to be slogans. So take a tip, set your limits, and bet responsibly. So, that provides really no guidance, no direction, and no advice on how to do that. It's a little bit like getting IKEA furniture without any instructions. Now, I know you don't have IKEA here, we did in Australia, but it is coming soon. So when it does arrive, look at the instructions. So our research has found that the reasons people fail in terms of implementing these strategies is that they choose things that were never going to work in the first place. So they'll say, oh, I can't get through the urges. They are unbelievable. But what I've done is I've told my partner and, they're going to help me. Well, that kind of puts a lot of pressure on the partner and actually doesn't have a set of, strategies for dealing with it. And so social support may be one part of an urge management strategy, but it's only a little bit of it. It might be that they make poor or unplanned transitions. So the person might say their strategy is absolutely to avoid being in places that serve alcohol. And then they go to a birthday and that ends up being in a place that serves alcohol, in a pub. So they're talking about a place that their primary job is alcohol. So they need to swap to a different strategy in order to what do they do when they're in that environment. People continue to use strategies that are not helpful, and it's really astonishing how often people do this. They say, I decided the best way was to, what am I going to do? Was to go for a run every time I get an urge to drink. Right. And then it's raining, they don't do that. And they go, well, I tried to do it, but it didn't really work because I tried it twice and then I still drank. And so what tends to happen is they either try to use things that aren't working, or they give things up prematurely. And so the idea of supporting people through a period of behaviour change is to try and address some of these issues. So, and you can do that with the backup planning that we talked about a little earlier. So I've come to the end, and what we have here is the website for the project. It's an international team of addiction specialists, including Chris Bullen here in Professor Chris Bullen in Auckland, and addiction specialists in Australia. So we are currently getting almost prepared to recruit to a project that is about sugar reduction, internet gaming reduction, pornography reduction, and general internet reduction. So they will be recruiting perhaps in March, and maybe I can provide some information when we get to that.
Great.
So we'll be doing these as not as RCTs at this point, so anyone can come in and try them out. Yeah. So.
And you've stirred up a lot of interest with regards to your taxonomy sheets and your pamphlets and booklets. People are wondering if these are available.
Yes. So we have the research papers available, but perhaps what I could do is with the sheets is to perhaps package something up for you if you were to help us as well. So perhaps what we could do is if we sent you some of these, a set of sheets, is perhaps if you would be involved in a small evaluation of whether they're helpful and how they could be improved. That might be a way to go, because one of the things is that this is still in that early stages, and we're keen to see how we can improve it and make it more relevant to people. Yeah.
Okay.
Fantastic. That's great.
Well, thank you very much. A video of this webinar will be available along with relevant links in the near future. Thank you everyone for joining us, and thank you, Simone.
Oh, thank you, Grace.
Great. Okay, and good night everyone.